Good afternoon, students. Do you hear me? If the sound is present. Okay, let's begin the lecture. The lecture is about blood transfusion. The lecture consists of 3 parts, and here are objectives for first part of the lecture. To describe the basic principles of blood bank service, to learn about blood products routinely used in surgery, to learn about blood typing, and to learn about cross-matching tests. Blood bank service and blood bank and transfusion service is the first chain in system of blood supply of clinical hospitals, and the blood bank service has some functions. Blood bank and transfusion services collect, process, store and provide human blood intended for transfusion, perform pre-transfusion testing and infusion into a patient. Often these processes may take place in a single hospital department, often they are performed in 2 separate places. For example, in many countries, most blood for transfusion is collected in blood centers, in special referral centers, which then process, store and transport it, blood for use by hospitals' transfusion services. Any hospital, clinical hospital, has its own transfusion service, which deal with transfusion of blood components into patients being treated in that hospital. The transfusion service is responsible for maintaining an adequate supply of needed blood and blood products, blood typing and cross-matching patients, and releasing the blood for transfusion. You should know some definitions about blood bank service. First definition, donor. Who is a donor? Donor is a person whose blood is collected for possible transfusion to another person. From whole blood, we can prepare some components. From the components, we can prepare products of the blood components and use them for treatment of patients in clinical hospitals. Second definition, recipient is a person who receives the blood for transfusion from the donor. This is indirect transfusion, when the recipient takes blood from donor. Unit of blood is a sterile plastic bag in which a fixed volume of blood is collected in a suitable amount of anticoagulant for preservation and stabilization of the blood components from decay, from lysis, during storage time. The collection system should be a closed system, usually consisting of a sterile hypodermic needle connected by tubing to a collection bag or bottle that has 1 or 2 sterile ports for inserting a sterile blood administration set. Indication for transfusion. Indication is any pathological condition or disease which must be treated with blood product or blood products. Blood bank and transfusion service involves selecting donors and assuring that they are informed. All the donors must be informed about downsides of the blood collection, of the blood taking from their cardiovascular system. Collecting blood from screened donors, Screened donors invited to clinical hospital or to blood bank center and being under collection of their blood samples, blood portions. Testing for blood components, antibodies, and infectious diseases. Collected blood should be tested before distribution to hospitals and should be being under quarantine storage. Storing and transporting blood. These are functions of referral centers of blood bank service. And the last two functions, pre-transfusion testing of recipient blood and transfusing patients. These are functions of clinical hospitals. Clinical hospital, any hospital has its own blood service, and the blood service deals with patients of the same hospital. What is pre-transfusion testing? Primarily, it's a defining definition of blood group, defining typing of blood into groups. And secondary, it's infectious disease testing. The blood portions should be tested to blood-transmitting diseases, such as syphilis. The method by screening with a standard antibody test. The blood should be tested to hepatitis B virus by testing for the hepatitis B surface antigens, HBs antigen, and HBV core antigen, anti-HBC, anti-HB core. Also for testing for hepatitis C virus by testing for anti-HCV, antigen of viral of hepatitis type C, and human immunodeficiency virus by testing for type 1 and type 2 antigens. Before the blood portions will be ready to distribution among the clinical hospitals, the blood portions should be being under quarantine storage. Quarantine storage when the whole blood or blood components should not be used for transfusion till the mandatory tests are completed and reported as non-reactive. The tests must be negative. The blood components and blood portions should not contain infectious pathogens. In order to ensure this procedure, the untested blood should be kept in quarantine storage. The units which test reactive, it means positive, any test should be segregated immediately and kept separately from other portions and kept in a separate quarantine area till sent for disposal. They should be they should be destroyed as biohazard substances. From blood portion, donor blood portion, we can prepare some blood products. Those blood products routinely used in surgical practice is a red cell concentrate, RBCs. Red cell concentrates sourced from whole blood donations are usually stored at low temperature, namely normal refrigerated temperature, 4 degrees Celsius. They can be prepared with apheresis or by centrifuging in special machines. Low temperature during storage reduces the metabolic rate of the red cells, stabilize them, and help to avoid possible bacterial growth. Blood donates must be prevented from hemolysis by adding preserving solutions in plastic bags, which are named as conservants, with the blood portions. The storage life with usage of stabilizer signified is 21 days, and if you will use Glugitsir as a blood stabilizer, you can keep blood portion for up to 35 days. Indications for RBT transfusion. The The main reason for transfusion of packed red blood cells is to increase the oxygen carrying capacity to meet the tissue demands for oxygen. The two primary conditions are for transfusion of RBCs. Actively bleeding patients, when acute blood loss is 25 to 30% of total volume of circulation, and level of hemoglobin less than 80 grams per liter. And second indication, when patients with chronic or symptomatic anemia. Indication to RBC transfusion appears when pharmacological correction of the anemia has no effect. You should know that any pathological state accompanied with blood loss has downside as reducing of oxygen carrying capacity. Reasons of blood loss can be acute and chronic. Due to acute blood loss, we have bleeding. Due to chronic diseases, we have anemia or chronic bleeding, repeated bleeding. Second blood product for transfusion in surgical room is fresh frozen plasma. Plasma is a component of whole blood which can be prepared by removal of blood cells from the blood donation. Fresh frozen plasma, abbreviation is FFP, is plasma that is derived from 1 unit of donated blood by centrifugation. It is frozen to at least 18 degrees below zero within 8 hours after donation. Storage in the frozen state is needed to prevent rapid loss of the coagulation factor activity. After thawing of the plasma portion, we can use the liquid plasma, thawed plasma at 36 degrees Celsius. We can use the plasma for treatment of hypocoagulative state and for treatment of bleeding. First indication for FFP is DIC. This is Disseminated Intravascular Coagulation Syndrome. This is clinical syndrome which complicates various critical states such as shock, for example, septic, hemorrhagic or hemolytic, or severe trauma, for example, Rash syndrome, major lung and cardiac surgery. Actually, by any major surgery can be complicated by DIC, and we should be ready for treatment of the DIC by plasma. Second indication is massive blood loss, when the patient lost above 30% of volume of circulation. With hemorrhagic shock, if the bleeding is major and complicated with hemorrhagic shock, you must use FFP for correction of coagulation profile of the patient's blood. Coagulopathy because of liver disease at chronic states such as liver cirrhosis or acute hepatitis. And last indication is indirect anticoagulant overdosage. Next blood product is a Cryo Precipitate. Is a very specific drug. Cryo Precipitate consists of a mix of proteins collectively called cryoglobulins. It is a compound that precipitates when fresh frozen plasma is thawed at 4 degrees Celsius. We can isolate the factors and collect them, keep them into mixture in special bottles, and use the Cryo Precipitate for treatment of hypocoagulation states. Cryo Precipitate consists of factor 8, factor 13, von Willebrand factor, fibrinogen, and fibronectin. Indications to use the plasma are hemophilia type A or hyperfibrinogenemia. Cryo Precipitate is a remedy for treatment of coagulopathy, continuous bleeding due to hypocoagulation of blood. After preparing of blood products, we should keep them in right conditions, in right environment, to preserve their properties, to preserve their features. Rules of storage of blood components. Red blood cells we must store in refrigerators. Range for storage from range of temperature for keeping of RBCs in refrigerator from 1 to 6 degrees Celsius. Normally it's 4 degrees Celsius. Blood cells have preserved with citrate phosphate dextrose solution, abbreviation is CPD. Glugicil, synonym is glugicil, can be kept for 21 days. If the blood cells have preserved with CPDA1 solution, they can be kept for 35 days. Plasma, if the plasma is frozen, we can keep the bottles with plasma in temperature 18 degrees below zero. If the plasma is thawed, we can keep the plasma in a refrigerator from 1 to 6 degrees Celsius after thawing. If the plasma is frozen, we can keep the hemacones with plasma up to 12 months. If the plasma is thawed, we must use the plasma for patients, or we must utilize the unused plasma within 4 hours. The same to Cryo Precipitate. 80 degrees below zero when it's frozen, from 20 to 24 degrees Celsius after thawing. We should keep the Cryo Precipitate in warm condition, in warm environment, 20 to 24 degrees, to optimize the action of coagulation properties of the plasma. If you store the plasma in a refrigerator, if you store the Cryo Precipitate in the refrigerator or with Cryo Precipitate, you can reduce properties of the coagulation profile, and treatment will be not sufficient for the patient. And last component, platelets, specific component in surgery, in surgical surgery routine, the platelets used for palliative treatment of patients with oncological intoxication. Oncological intoxication means neglected stage of malignant tumors that suppress hematopoiesis, and the patients have hypochromic anemia. Platelet concentrates are stored at room temperature. Temperature should be about 22 degrees under gentle agitation. In special machines, in special environment, technical environment, bottles with platelets or hemacones with platelets should be gently agitated during keeping in room temperature. The length of platelet storage depends on the container and the method of collection and processing. If the system for collection of platelets is closed, we can keep the thrombocytes for up to 5 days. Whereas an open system, for example, open bottles, open platelets, we can typically store the platelets for 24 hours only, during 1 day. After that term, we should destroy, we should utilize the unused platelets. After obtaining of the medium drugs, blood products for transfusion, we should observe specific technique for transfusion. When we have blood products and when we have patient needed for transfusion, we should keep some rules. First rule for hemotransfusion is relate the indications and contraindications for transfusion. At first, we must observe our patient and relate the indications. It means we should diagnose the conditions, diseases, or pathological states which require blood transfusion for their correction. After that, we should order the necessary blood product in hospital's blood bank service. After that, we should perform the blood typing tests of the recipient blood in compliance with ABO and RH antigen systems. We should type of patient's blood into groups according to ABO system and according to Rhesus system. After that, we should select the blood products that should be transfused according to indications and ensure its microscopic validity. Next, should repeat testing of the donor blood from RBC spec to confirm the ABO group and RH, Rhesus vector. Cross-match the red cells of selected donor against the serum or plasma of the recipient to be sure that there are no ABO and Rhesus problems. Next, we should perform the biological test and we can start the transfusion. When the transfusion is completed, we should record administration of the blood or blood products in patient's chart and provide the post-transfusion supervision for the patient. Pre-transfusion testing of blood. Blood group is a congenital combination of antigens and antibodies from two strong and clinically important antigen systems, ABO and RH, Rhesus system. Determination of ABO group should be determined by testing red cells with anti-A, anti-B and anti-AB reagents. We should use monoclonal antibodies, artificial monoclonal antibodies for typing of erythrocytes. Determination of RH or D-type, determination of Rhesus vector. The Rhesus vector type should be determined with anti-D reagent. When the test for D is positive, the label should read RH positive. When the test for T is negative, the label should read RH negative. When the antigen D presence on erythrocytes, the patient should be considered as RH positive. What is a blood group? The blood group is a congenital combination of agglutinogens and antigens on RBC's membranes and presence of agglutinins and in plasma of the same patient. Blood group is a combination of dissimilar antigens and antibodies. For example, red blood cells, we have red blood cells and we have plasma. In this case, we should determine presence of, type of erythrocytes, we should discover antigen sets on them. If the erythrocytes contain antigen A, the plasma will contain antibody beta, anti-B antibody. Type B, if the erythrocytes contain antigen B, the plasma of the same patient will contain antibody alpha. Type AB, erythrocytes contain both anti-A and anti-B antigens, and plasma have neither antibody, no antibodies present in the plasma at the same time. And type O, erythrocytes do not have antigen A or B, but plasma has both antibodies alpha and beta. Isohemoglutination is a universal reaction that we can use for typing of erythrocytes. Isohemoglutination is immune reaction that takes place in blood due to contact between similar agglutinogens, these are antigens, and agglutinins of plasma. Two variants are possible. For example, type A blood donated to type A recipient, they will be compatible. The blood does not cause any agglutination. Blood donation does cause any agglutination because the recipient anti-B antibodies not fit to A antigen of donor's blood. The second variant, type A blood donated to type B recipient. This similar blood, they will be incompatible because it causes the agglutination because recipient's anti-A antibodies, alpha antibodies, will fit to the A antigen of erythrocytes. And in this case, agglutination will be present. Technique of the reaction. Very simple technique. Duration of the test takes 2.5 or 3 minutes. We should have a set of reagents, anti-A and anti-B reagents, monoclonal antibodies. You should have a laboratory dish for blood typing and special rooms for hemotransfusion, for pre-transfusion testing, that presence in any clinical hospital. Temperature of environment must be from 15 to 25 degrees. The laboratory dish for blood typing must be dry and clean. This is very important to avoid pollution and dilution of the reagents with water or any other liquid. The portion of blood and portion of monoclonal antibodies must be mixed in proportion 1 to 10. It means one portion of blood should be combined with 10 times more larger portion, 10 times larger portion of antibodies. Exposition should be not less than 2.5 or 3 minutes for complete reaction of the immune components. And the result of the test. The positive agglutination with antibodies shows the similar antigens presented on donor RBCs. RH blood typing test. How to define the presence or absence of defect on erythrocytes. If donor blood is incompatible to serum of the recipient, agglutination with following hemolysis will occur. The technique of the reaction is similar to blood grouping according to ABO. You should combine erythrocytes with anti-D monoclonal antibody. RH positive, antigen D presence on RBCs, clamping of erythrocytes with the presence, and RH negative, antigen D is absent on RBCs, so the agglutination is absence, clamping of erythrocytes absence, and reagents will be lucid, transparent. Cross-matching tests. After typing of blood, we can select blood component with the same group to our patient. And we can perform cross-matching tests. The purpose of pre-transfusion testing is to select blood or blood product that will not cause harm to the patient, to recipient, and to ensure that the red cells will survive when transfused. When the test is performed properly, the cross-matching tests will confirm compatibility between selected samples of donor blood with the recipient's blood. A sample of donor RBCs from the back and recipient serum or plasma should be cross-matched with ABO compatibility test, RH compatibility test, and biological test. ABO compatibility test, the technique, the same conditions, room for hemotransfusion, laboratory plate for transfusion, and we should combine the serum of the recipient and donor red blood cells in the same planchet and wait for 5 minutes. After 5 minutes, we can check out the results. If the blood clamping is absent, the donor blood is compatible to recipient serum. If the aggregation of red blood cells present, the blood is not compatible, means erythrocytes will be clamped and destroyed. Donor erythrocytes will be destroyed by antibodies of the recipient plasma. We mustn't transfuse this blood portion in any case to our patient. Test on RH compatibility. We should use 3 test tubes. This is worm test with gelatin solution. We should use test tube with 2 portions, 2 drops of gelatin, 2 drops of patient serum, and 1 drop of donor RBCs. We should mix them in the test tube and put into water bath for incubation during 10 minutes at temperature 36 to 38 degrees. After incubation, we should dilute the portions with isotonic sodium solution and investigate under microscope. And depending on the results, we can make conclusion. Non-glutination means donor erythrocytes compatible to recipient plasma according to Rhesus system. If the donor erythrocytes are clamped, the blood portion is incompatible, and the erythrocytes will be destroyed by antibodies, by plasma of the recipient after hemotransfusion. And last, biological test. This is intravenous test, bedside test. You should give 3 portions of donor blood for 20 to 25 ml each with intervals for 3 to 5 minutes to the recipient intravenously. And next, you should observe 2 very important points. Ask the patient to report any bad signs such as chills, headaches, low back pain, chest pain, itching or rash immediately as they appear. And observe the patient for flushing, for pathological changes. I mean, if the patient presents itching, difficulty breathing, hives or other rash when checking vital signs, it means the blood is incompatible according to recent blood antigens. Any clinical sign from the listed above indicates to incompatibility of donor blood component to your patient. You must utilize the blood portion. You must send the blood portion to investigation in blood bank service, referral center, for discovering of reason of the incompatibility. Cross-matching test for other blood components. Cryo Precipitate. The component should be thawed at temperature of 37 degrees and used immediately. ABO compatibility should not be must because thrombocytes do not have any antigens critical for the patient, for the recipient immune system. Fresh frozen plasma transfusion should be ABO compatible. It means you must select a plasma the same group from donor of the same group as your patient is. And product that have been thawed should be infused without delay to avoid bacterial proliferation of the plasma. Cross-matching tests are usually not performed on plasma products, but biological test is needed. And method of hemotransfusion. After completing pre-transfusion and cross-matching tests, you can use various methods of transfusion. Actually, what is a transfusion? Is infusion of blood or blood components, blood products, into a living being. Blood for transfusion can be derived from various sources. Autologous transfusion. If you will transfuse blood taken from the same patient, is stored and then infused into the same patient. The patient receives his or her own blood. This is autologous transfusion. And allogenic transfusion. Synonyms are isogenic or homologous blood transfusion. When blood from another genetically distinct individual of the same species, a blood donor, is infused from another human. Is a transfusion of blood into a human from another human. This is allogenic transfusion. Indirect allogenic transfusion. Now take a break for 10 minutes. Okay, let me resume my lecture. Second part of the lecture. Transfusion-induced complications and reactions. Objectives of this part. To describe the main mechanisms of transfusion-induced complications, to classify the transfusion complications, and to learn how to treat transfusion hemolytic shock. Definitions. Recipient transfusion reaction is adverse reaction to infusing blood or blood products into a patient, into a recipient. It may occur at any time during the transfusion, but often happens shortly after starting it. Immediate reactions may be mild or severe and rarely is fatal. Types of reactions include non-hemolytic, from mild itching and hives to serious breathing problems, and hemolytic. Reaction as well as a fever, chills, rapid heart rate, hyperventilation, fainting, and cardiac arrest. So the delayed reactions, several days or weeks after transfusion may occur. It may be due to weak antibodies in recipient serum directed against antigen on the donor blood cells, undetectable at the time of pre-transfusion tests, and result in delayed hemolysis or unexplained fall in hemoglobin. So there are two types of reactions, immediate and delayed, and two mechanisms of reactions, non-immune and immune-mediated. Post-transfusion complication is a severe pathological state or dysfunction which occurs due to wrong procedure of hemotransfusion. And post-transfusion reaction is a functional response of the recipient to donor blood components. Classification, they can be immediate, complication or reaction starts just after transfusion begins, or delayed, complication or reaction happens since few days or weeks after transfusion. Classification of immediate non-immune reactions. Type of reaction, air embolism, is occlusion of blood vessels by air bubbles got into bloodstream through equipment of hemotransfusion. Clinically manifested with cough, dyspnea, chest pain, and acute cardiac failure. Circulatory overload, second type of reaction, overload, complication, is acute pulmonary edema due to large blood volume infused too fast, very fast, intravenously. So due to overloading of patient's circulatory system, the patient manifests with dyspnea, severe headache, hypertension, tachycardia, and acute heart failure and pulmonary edema. A result of overloading of right parts of the cardiovascular system. Next complication is septic shock. Transfusion of infected blood components due to presence of bacterial pathogens and their toxins into the donated blood portions. Clinically manifested with symptoms of acute bacterial intoxication. Immediate immune-mediated reactions. Three types. Immune-mediated hemolysis. Hemolysis is a demolishing of erythrocytes due to activation of complement system. Due to hemolysis, we can find hemolytic shock due to transfusion of ABO or Rh incompatible erythrocytes caused by complement fixing antibodies. Symptoms of hemolysis are chest, abdominal or low back pain, acute dyspnea, tachycardia and hypotension, hemoglobinemia and hemoglobinuria, presence of fraction of free hemoglobin in bloodstream, and presence of hemoglobin in urine. Oliguria with dark urine or anuria, nausea and vomiting. So symptoms of acute hemolytic shock, first stage, symptoms of acute renal failure, second stage, and recovery of the patient or death of the patient from hemolytic shock. Second type of the immune-mediated reaction is a febrile non-hemolytic reaction. This is a fever associated with transfusion due to presence of leukocytes in RBC hemocon with RBCs, mass of fresh frozen plasma. Antigens of leukocytes cause febrile non-hemolytic reaction. Clinical presentation is high body temperature, subfebrile temperature, just above 37-38 degrees Celsius. Pale skin, paleness of skin, and chillness. And third type of immediate immune-mediated reaction is anaphylactic reaction. This acute allergic response to donor's proteins, which a residual amount of them present in any pack with RBCs or leukocytes, due to presence of proteins, albumin, immunoglobulin A, immunoglobulin G, etc. Clinically manifested with chest tightness, cough, it means pain behind the breastbone, skin rash as a reaction of skin to immediate immune reaction, hypertension, nausea, abdominal pain or vomiting. Delayed reactions and complications. Non-immune delayed reaction, transfusion-induced infection. Infection may happen due to infecting of recipient body with pathogens, viral or bacterial pathogens present in donated blood. The recipient can be infected with hepatitis, usually blood transmitting variants of hepatitis, hepatitis B or hepatitis C. With human immunodeficiency virus, HIV infection, with cytomegalovirus, with malaria, syphilis or toxoplasmosis, due to mistakes in blood transfusion services. And immune-mediated reactions and complications delayed variant, post-transfusion hemolysis. This is lysis of erythrocytes, second time donated erythrocytes by the recipient antibodies produced due to previous hemotransfusions. If a patient has repeated hemotransfusions during the first transfusion, he can be immunized against donor erythrocytes, and immune system of the recipient can produce of antibodies to erythrocytes. And during repeated transfusion of erythrocytes, recipient body can produce delayed hemolysis. Clinical symptom, clinical presentation the same as for acute hemolysis. But the hemolysis happens since in a few weeks or in a few days after transfusion.
Тоже, да?
Тоже. Immune-mediated reactions and complications. And last type of the reaction, graft versus host reaction. I mean, permanent lysis of recipient's RBCs by antibodies produced by donor lymphocytes engrafted in the recipient's body during prior hemotransfusion. Clinical presentation is fever, nausea, vomiting, diarrhea, skin manifestation as a skin rash, and laboratory manifestation as a pancytopenia or disturbance of coagulation profile of the recipient, such as disseminated intravascular coagulation syndrome. And last aspect of this part of the lecture is the treatment of hemotransfusion shock. This is shock, acute circulatory disturbance, which happens with a result of post-transfusion hemolysis. What should we do with patients falling into hemotransfusion shock? First, we must stop the transfusion immediately. We must close the valve set for intravenous transfusion and remove the bottle from the bedstand and connect the intravenous set for intravenous transfusion with anti-shock remedies. Next, should we do cardiac support with blood substitutes? We should use anti-shock blood substitutes for supporting cardiovascular system of the patient, because shock, first of all, is a disturbance of cardiovascular system. Next, action is a respiratory support. Oxygen supply or tracheal intubation with AVL. If the patient is fully conscious, we can use nasal catheter or face mask for ventilation of patient's lungs and for supply of gaseous mixture with oxygen. If the patient is unconscious rapidly or due to prior disease, we should intubate of the patient, perform endotracheal intubation, and connect the patient's lungs to machines for AVL. Next point is the prevention of acute renal failure with sodium bicarbonate solution. Mechanism of action is a stoppage of intrarenal coagulation of hemoglobin. Due to hemolysis, we can see very strong acidosis. Mechanism of action of the sodium bicarbonate is a neutralization of acids and increasing of pH. First aid triad is a classic anti-shock combination of drugs for stabilization of patient's cardiovascular system, microvasculature, and preserving of immune cells from liberation of antibodies, from originating of immune response. Combination of drugs. First drug is a prednisolone, is a hormone of epinephrine glands. The hormone is stabilize blood vessels. They maintain blood pressure and preserve the basophils from degranulation. Euphyline is a drug for relaxation of smooth muscles. We can use euphyline for improving of lung circulation and for improving of ventilation of small bronchi via the small bronchi of the patient to prevent bronchial obstruction. And last part of the triad is a Lasix. Lasix is a diuretic. Maintain production of urine in kidney and to prevent of coagulation of hemoglobin in the epinephrines. Antihistamine drugs. Drugs for stabilization of basophils. The drugs prevent degranulation of basophils and releasing of biological active substances. And the last point of the treatment is a correction of impaired blood coagulation profile in case of disseminated intravascular clotting syndrome. Depending on the stage of the syndrome, we can use heparin solution in the hypercoagulative state or fresh frozen plasma in hypocoagulative state of the syndrome. Third part of the lecture is fluid management. Please take a break for 5 minutes. 5 minutes break, and then we will resume our lecture. So the last part of the lecture, part number 3, information about fluid management for correction of blood loss and correction of various indications for transfusion. Objectives of the third part are to explain the importance of fluid therapy in blood management, to classify the plasma substitutes, and to learn about the role and mechanism of action of plasma substitutes in volume therapy. Importance of the fluid management, fluid therapy. Circulating intravascular volume is essential for survival. Functions of intravascular fluid volume. The fluids expand the plasma volume and guarantee cardiac output. They carry blood cells, oxygen, nutrients, metabolic byproducts, and drugs via the blood circulation. The fluids cause changes in the microvasculature, coagulation profile, and rheology of blood. All intravascular fluids have a profound impact on the water and electrolyte balance of the body. Key definitions of the fluid management system. What is a blood substitute? It is artificial solution for replacement of one or several impaired functions of blood. The blood substitutes, according to chemical structure, can be crystalloids and can be colloids. Crystalloids are solutions that contain electrolytes or other small solutes. Their molecular weight does not exceed 30 kilodalton. Crystalloids have zero colloid osmotic pressure. And colloids. Colloids are solutions that contain substances with a molecular weight exceeding 30 kilodaltons. Their dispersed particles are between 1 and 10 nanometers in diameter and cannot be separated by filtration or gravity. The colloids exert a colloid osmotic pressure. And volume therapy. Actually, volume therapy is the replacement or expansion of plasma volume to achieve an optimal intravascular fluid level, to restore osmotic pressure and to influence rheology and to ensure microvascular perfusion. Plasma substitutes can be classified according to clinical usage into 4 groups. Nowadays, into 4 groups. First group, drugs for hemodynamic action. Synonym of the group is plasma expanders or anti-shock fluids. The group consists of derivatives of dextran, derivatives of gelatin, and hydroxyethyl starch. Second clinical group, regulators of the water and electrolyte balance of the body. Then it involves crystalloids, regulators of acid-base balance, and osmodiuretics. Third group is detoxicants, various derivatives of polyvinyl pyrrolidinone. This is multi-atomic spirit. And fourth group, solutions for parental nutrition. Amino acids, fat emulsions, carbohydrates, or combined solutions. First clinical group, plasma expanders. This group involves derivatives of dextran, for example, Reardex, Neurondex, derivatives of gelatin solution, gelofusine or gelatinol, and derivatives of hydroxyethyl starch as such as stabizol, rifampicin, volubene. Mechanism of their action. The colloids consist of large-sized molecules, and they cannot escape capillaries and be present in the cardiovascular system. They stay in blood vessels long time and increase intravascular volume because of attraction of water. They attract water from the tissues into the blood vessels and increase and maintain of intravascular volume. Indications for transfusion of the plasma expanders are shock, for example, traumatic, hemorrhagic, or toxic variants of the shock, various hypovolemic states, collapse, and anaphylaxis. Anaphylaxis is a result, for example, for correction of redistribution, pathological redistribution of blood due to liberation of biologically active substances. What is a plasma expander? What is a dextran solution? It's a glucose polymer. It is synthesized by enzymes of leuconostoc mesenterioides. These are bacteria. This bacterium produces dextran of very high molecular weight. Hydrolytic breakdown and fractionation finally lead to different dextran preparations. We can fractionate all the dextran, initial fraction of the dextran, we can divide into subfractions. And finally, for clinical use, we have dextran solutions as dextran 40. 40 means average molecular weight of 40 kilodalton. And dextran 70, average molecular weight of this molecule, 70 kilodalton. They are available in concentrations, 3 or 10% solutions. Initially, dextran has an excellent volume increasing effect, but the effect is only short-lived. Because of the small molecular size, dextran is excreted rapidly with the system. Second clinical solution for hemodynamic action is the hydroxyethyl starch solutions. HES abbreviation is a synthetic colloid made from corn or potato starch. This starch is the basis for the production of amylopectin, a glucose chain. Hydroxyethyl starch solutions are available in two concentrations. The percentage gives the concentration of the starch solution. 6% solution is considered isotonic. 10% solution hypertonic solution. Hydroxyethyl starch solutions reduce extravascular leakage of colloids caused by microvascular hyperpermeability and sealing effect on the capillaries or the inhibition of endothelial activation and damage may occur. It means they stabilize of vascular membrane, they seal microvasculature and prevent fluid leakage syndrome when the fluid after starting of the transfusion escape from vessels into interstitial space. And lastly, hydroxyethyl starch may also modify severe inflammatory responses and reduce endothelial dysfunction. It may be organ protective. It may give organ protective function in sepsis and major surgeries. And the last chemical substance is gelatin. We can use gelatin modified polypeptides from bovine collagen. Gelatin is available in solutions of concentration of 4, 6, and 10% and is dissolved in sodium chloride solution in isotonic sodium chloride. The average molecular weight of gelatin is from 30 to 35 kilodalton. This is far below the regular threshold of approximately 60 kilodalton. So the gelatin therefore rapidly excreted from the bloodstream. Next group, regulators of the water and electrolyte balance of the body. What means regulation? Mechanism of action. Crystalloid solutions, 0.9% of sodium chloride, Ringer solution, Ringer lactate solution, Phillips solution, lactosol solution, or solutions of osmodiuretics, 15% solution of manite or 20% solution of sorbitol. They can pass through membranes and touch the interstitial space of the body, permeate from blood vessels into interstitial space, into soft tissues, and restore buffer capacity of blood and reduce metabolic acidosis. As you know, extracellular and intracellular fluids very rich into salines, various crystalloids, for example, potassium, sodium, chlorine. These solutions are very useful for correction of intracellular water impairment. Indications for transfusion of crystalloids are dehydration. Various variants of dehydration, for example, isotonic dehydration, as a result of vomiting, perspiration, or diarrhea. We can use these solutions for correction of metabolic acidosis or for correction of intoxication, for dissolving the toxins into bloodstream regarding to improvement of microcirculation and increasing of intravascular, cellular, and intracellular volumes. Third group is detoxicants. These are drugs for treatment of various intoxications. According to chemical nature, they are derivatives of polyvinylpyrrolidol. Pharmacological examples, gluconeodes and neohemodes. Mechanism of their action, absorption of various toxins, inactivation of the toxins, various toxins, metabolic, bacterial toxins, and removal them from bloodstream through kidneys very fast. Actually, they decrease blood viscosity, they improve renal circulation, and increase diuresis. They provide high diuretic effect. So the indications for application of detoxicants are various inflammatory diseases. For example, peritonitis, inflammation of peritoneal cavity, sepsis, general systemic inflammatory response to bacterial invasion, various intestinal infections, and detoxification and surgical purulent diseases of soft tissues and bones. And last group of solutions, drugs for parenteral nutrition. When the patient is improper to take fluid or nutrients orally, we should provide nutrition of the patients via blood circulation. We can infuse sterile solutions, isotonic sterile solutions of nutrients into bloodstream, and we should maintain metabolism, general metabolism of the patient. We can use isolated drugs for correction of different chains of metabolism, such as amino acid solutions. Names of the solutions: hepasol A, aminosol, or aminosterol. We can use fat emulsions for improvement of fat metabolism, lipids, intralipid or omega-1. We can use carbohydrates, glucose solutions. In our country, percentage of the glucose varies from 5 to 40%. Commonly used 5% of solution isotonic. In severe states, we can use hypertonic solutions of glucose, or we can use combined solutions. For example, names, the pharmacological names, polyclinamyl and toluene central. Mechanism of action is very simple to understand. Is a supply to natural metabolism of cells and tissues. And indications for usage of drugs or parental nutrition. Very understandable. Any pathological condition when the patient cannot take fluid orally. What are the states? Elementary cachexia, for example, bad patients, sepsis, severe post-operative period with, after major surgeries, after cardiovascular surgeries, after operations on gastrointestinal tracts, lungs, respiratory system, kidneys, when the post-operative state is very severe and the patient cannot take fluid during several days. That's all. My lecture is finished. If you have questions, please you can ask me your questions. Please, I'm waiting for your questions. If you have no questions, you may be free. The lecture is finished. See you next week.